Dear friends, welcome once again in the live interactive teleconference of the Postgraduate Diploma in Geriatric Medicine. Today we are going to discuss the common emergencies in geriatric patient, as well as poisoning and accident, as well as balance disorder of the geriatric patient. To discuss these two topics, we are having experts from Maulana Azad Medical College. Next to my left is Professor P. Kaur. He is Professor of Medicine, Maulana Azad Medical College, New Delhi. And next to Professor Kaur, she is Dr. S. Anuradha. She is Associate Professor from Medicine Department in Maulana Azad Medical College. So the first topic, that is the common emergencies in geriatric medicine, geriatric patient, has been taken by the predominantly Dr. Anuradha. And dear friends, as all of you know that geriatric patient as behave differently because their physiological process, as well as their body metabolism and all the body systems are entirely different from as the adult as well as pediatric age group. So the different emergencies regarding those patients are also very different. So there are emergencies like dyspnea, chest pain, arrhythmia, maybe it hypothermia, maybe it is hyperthermia. So regarding all these common emergencies of the geriatric patients, Dr. Anuradha will discuss in details to make you more understand. And all of you are requested to ask or interact to Dr. Anuradha whenever if you have some problem to understand regarding any issues. So not wasting too much time, I would like to request Dr. Anuradha to start with the topic. Dr. Anuradha, please.
Thank you, Dr. Biplab. Good afternoon, all of you. Today we are going to discuss about emergencies, common emergencies that are seen in geriatric patients. As we know that the physiology of the aging adult is very different from the young adult, and so although the kind or spectrum of diseases that presents in younger adults and older adults are almost similar, but however the clinical features, the clinical presentation, the outline to management, the response to therapy and the complications that occurred in elderly patients are quite different from that occurred in the younger adult. Hence, it is important to be able to recognize early the common emergencies that are encountered in geriatric medicine and to deal with them appropriately, so that since many of these have higher morbidity and also higher mortality because of the changing physiology in the elderly population. So we shall be briefly discussing some of the common emergencies that are seen in the geriatric patients, and we will take them up system by system and talk about some of the common presentations and how these emergencies actually differ from that are seen in the younger adults. That is what we will be discussing about. May I have the slides, please? Okay. What we are going to talk about are some common geriatric emergencies. Very briefly, we must first talk about assessment of the geriatric patient when a patient presents in the emergency department. This is slightly different and slightly more difficult in certain situations as compared to assessment of a young adult or a slightly older adult. And this assessment of the elderly is slightly different because of the following factors. Because of variability in the types of presentation, the response to the illness with which the patient comes, there may be multiple pathologies that may be present in the same patient. There could be altered illness or injury presentation different from that occurs in a young adult. Many elderly patients are using multiple medications which may alter the presentation or entirely change the outlook of the patients, and of course we shall be dealing very briefly with the communication problems. Let's start very briefly describing some of the factors that can complicate assessment of a geriatric patient or an elderly patient who presents in the emergency department. It is very important to remember that older people differ from one another more than younger people do. The reason for making this statement is that suppose an elderly patient presents with pneumonia or a patient has a pneumonia, two elderly patients or two geriatric patients who will have consolidation or a pneumonia are very likely to be very different from each other as far as clinical manifestations are concerned. This is very different from young adults who generally tend to have more typical manifestations, and two patients with pneumonia are likely to present much more in a similar fashion as compared to those who present in two elderly adults. So what it basically means to say is that there is a significant variability of presentation even among elderlies, let alone compared elderlies to the younger adult. The other thing important to remember is the response to illness. How adults or how elderly patients generally respond to illness. It is very important to remember that many of them seek help for only small part of their symptoms. For example, they could be having cough, they could be having expectoration, they could be having breathlessness, but they may not attach importance to each of these symptoms and may seek attention for only one. So it is our responsibility to take a good history, do a detailed physical examination and put all these complaints together in a coherent manner so as to arrive at a particular diagnosis. Another important component that we must remember is that many people, not only the elderly patients per se, but even the caregivers just perceive their symptoms as getting old. So if an elderly has had a fall, a very trivial fall even from a bed, and is behaving slightly abnormally, mild neuropsychological manifestations, one should not suspect or one should not attribute it just to the fact that a person is getting old, so it is a senility problem. It could be a much more graver, serious problem like a subdural hematoma, which can present with very trivial manifestations. So it is extremely important not to trivialize symptoms or signs or manifestations which elderly patients may have. Because of this tending to trivialize their symptoms, many patients actually delay seeking treatment, so by the time they come to us, they may be having very significant morbidity attached to the symptoms and they may be coming with late complications of the illness. So it is extremely important to remember to always realize that elderly patients as well as their caregivers may actually be trying to trivialize chief symptoms which may mask the kind of presentations the patient actually has. Another important thing to remember is that many elderly patients actually have multiple pathologies which are operating at the same time. More than 85% of them have one chronic disease and 30% of them have 3 or more illnesses at the same time. What this does is that since patient may be having chronic obstructive airway disease, may also be having coronary artery disease, may also be having diabetes, suppose a patient has all 3 of these ailments and comes with a 4th complaint, both the patient himself, the patient's attendants may actually attribute that new complaint to maybe one of these 3 already underlying illnesses. So he may tend to trivialize it, tend to neglect that complaint. The second thing that can happen is that each of these individual complaints or diseases which the patient actually has underlying may mask or unmask the symptoms of a new illness. So, or what may happen is one symptom or one disease may actually exacerbate or actually mask the symptoms of the other. So what it actually means is one symptom's acute illness stresses may stress the other's reserve capacity. For example, suppose somebody has an underlying coronary artery disease and maybe ischemic cardiomyopathy. This patient suffers from a fever and a pneumonia. What will happen is this fever actually tends to worsen the congestive heart failure. So the patient may actually present with congestive cardiac failure, while the problem which actually has occurred now as an emergent situation may actually only be a pneumonia. So that is how one complaint can actually cause a stress on another system presenting with entirely different kind of manifestations. And like I said, one disease symptom may actually mask another symptom. For example, dyspnea may be due to many causes. Dyspnea may have cardiac origin, dyspnea may be of respiratory origin. So you never know if a patient is presenting with dyspnea. So if he is already having COPD, he may not actually, and his lung reserve is very poor, you may not actually pick up the signs of congestive cardiac failure very well. So sometimes one disease may actually mask the presentation of another. So that is what it is important to remember, that since they have multiple pathologies or multiple conditions that are operating simultaneously in the patient, the disease presentation may be very variable in individual patients. The next thing one must remember is that it is very common actually for having atypical presentation. Young adults will present with very typical classical textbook presentations of all kinds of diseases, whereas elderlies are more prone to develop or more prone to present with altered presentation. The reason for these is they have a diminished pain threshold, so they may not actually perceive very severe pain as severe pain. They may say they have mild chest pain or just mention it as a discomfort. They have very depressed thermal regulation, temperature regulation, so they tend to have environmental toxicities or environmental emergencies like hypothermia or hyperthermia very fast. They have depressed thirst mechanisms. So even if they are losing fluid through maybe GI losses like diarrhea or vomiting, because the thirst mechanisms are suppressed, these patients tend to go into renal failure much faster because of the input of water or the intake of water is not commensurate with the losses. So these are physiological processes that are actually affecting the compensatory mechanism or the adaptability of the body to certain stresses. Another common manifestation that occurs in elderly patients, irrespective of the underlying disease, is neurological manifestations. You will find that elderly patients with pneumonia, with a chest infection, with a urinary tract infection, with meningitis, all of them can actually present with confusion, restlessness and hallucinations. And this could be, what is important to remember from this is, any elderly patient who presents with confusion or hallucinations or delirium does not necessarily have a neurological problem. He could be just having an infective process somewhere. So you need to be very thorough in examination and investigations when we need to find out the cause for alteration of sensorium in an elderly patient. They have generalized debility and they can have very poorly, vaguely defined complaints, which again makes the diagnosis in these patients slightly difficult. Another important problem to always remember when we are dealing with elderly patients is communication problems. They have difficulty in communicating with others around them, and hence because of that they are actually not able to communicate their problems or their symptoms with great efficiency. So this is because of diminished sight, diminished hearing, diminished mental faculties. They could be just having mild depression, which makes them a little bit more difficult to understand, and you may sometimes find that they are a little uncooperative at times. So they may have limited mobility, so we may not be able to turn them around in bed as much as we would like it to examine them. So we must remember all these kind of problems when we are dealing with adult patients or elderly patients, so that we may be able to pick up important findings and not miss findings which may be so subtle that if missed we may actually have a wrong diagnosis at hand. So these are some of the important points in history that we must always remember before we actually go further to examine these patients. Another very important point to consider in geriatric population is the concept of polypharmacy. Like we talked, that many of them have more than one disease conditions, so many of them are actually taking too many drugs. So if a patient is a diabetic, is a hypertensive, is also having coronary artery disease, he may be having a list of drugs which could go into 10, 12 drugs. Each of these drugs will cause its or own side effects. It will have its or own toxicity. It will have its or own interactions with other drugs and with newer problems. So one must always remember the concept, or one must always keep in mind that these patients may actually be taking more than one drugs, which as such may be affected by the aging process of disease, of elimination of these drugs may be altered. So you may have the markers of drug toxicity that develop in these patients much more commonly. And it's also important to remember that 30% of geriatric hospitalizations are actually drug induced. So they could be having some kind of drug toxicity, some drug interaction, which actually makes these patients more difficult to manage. Another important thing, when we take all these things in mind, it is important to remember that the chief complaint may be very trivial or non-specific. He may be just having mild, he may come to the emergency saying he is not feeling very comfortable, or he is just having mild chest discomfort. This could just be the presentation of a very severe myocardial infarction because of autonomic neuropathy which develops in these patients. The pain threshold may not be very good, so they may not be actually feeling much severe pain as a younger adult would have felt. And another thing to remember is, many times these patients may not volunteer information. They may not actually report these complaints because they feel that they will be a burden on their family, or there could be some other problems that they don't want to actually talk about these complaints. So one must remember these points again when we are taking a history from these patients. How do you deal with communication difficulties in these patients? Talk to the patient first. Always try and elicit the history from the patient himself or herself. It is always better because the patients have the best idea of what is going on with their body. If possible, talk to the patient alone without the presence of the caregiver or the attendant. Sometimes they may fear the caregiver, there may be some kind of a social neglect on part of the caregiver, so sometimes you may not be able to get this history if the caregiver is actually around. But of course, if the patient himself or herself is in an unconscious state, or is in an altered state or a drowsy state, then one has to rely upon the attendant or the caregiver, whoever has been with the patient for us to get a good history from. You must have a very formal, respectful approach. Always position yourself near the middle of the visual field. Why we tend to do this is that they may be having a restriction of visual field, they may be actually not be able to see you well. Talk to them clearly, speak slowly. Do not assume they are deaf and do not shout out loudly. It is very disrespectful. Sometimes they may actually not like them being shouted at. So stand close to them, speak slowly, speak clearly, speak in a language that they understand, and take their history very slowly and try to elicit as much information as we can from these patients. Another very important point to remember is, do not assume a patient is just senile. Any lack of sensorium, any alteration in sensorium, any confusion, even though very mild, should not be attributed to being just because of senility or old age or age related. It could be the marker of a very serious and very important underlying illness, which we may just miss if you just trivialize a very simple complaint. One must obtain a very thorough history. Remember that although the patient has come to this hospital or to you in an emergency department, the patient may actually be seeing more than one doctors for more than one complaints. So he may be taking multiple medications, he may have multiple problems. There may be shared medications. Although you are giving an antihypertensive to one patient, he may not be taking it. He may be giving part of his medication to somebody else. So these are some things we must remember. Over-the-counter medications. Many times if they are having pain, they may just take in non-steroidal analgesics from over-the-counter, which are very easily available. So these may actually mask the illness. These may actually lead to own complications like GI bleeds, which are quite common. Even a single tablet of aspirin can give rise to very severe gastrointestinal bleed in the elderly patients. So these are some points that we must remember while taking a history in the geriatric patients. While coming to physical examination, very briefly, examine the patients in a warm area because they tend to get very cold and hypothermic, so keep them warm. They may fatigue easily, so do not keep on pestering them with questions. They may just give up at one point and say, that's it, this is all I am going to tell you at this point of time. So one needs to bear with them because they tend to be non-cooperative at times. They may have difficulty with positioning. You may want to auscultate the chest, but they may not be able to sit up straight. They may have a problem with their spine or with their knees or with their hips, so they may not be able to assume postures that we would like for a better examination. So we will need to examine them in the position that is most comfortable to them because they may not be able to assume other positions because of underlying problems. There may be decreased pain sensation and that may require a very thorough examination. The components of the physical examination that may be quite misleading are, since elderly patients, very elderly patients tend to have inelastic skin, loose skin, it may actually mimic a decreased skin turgor. It should not be taken as a sign of significant dehydration because there may be loss of skin elasticity as with old age. Many times these patients tend to have mouth breathing. So again the oral mucosa may be dry. So that should not be taken as a sign of severe dehydration. You should look at all the signs put together before you actually arrive at this condition. Many times, many of these patients are actually non-ambulatory in the sense they always keep sitting with their feet in a dependent position, and just because of this dependent position, these patients may at times develop mild pedal edema. That should not be taken as a sign of an underlying serious congestive cardiac failure, and one must look for other signs to corroborate the presence or absence of congestive cardiac failure. Many times they may have small basal atelectasis of the lungs because they are not using very deep breathing. So you may actually get creps on the lung basis, and you must not attribute them to always being pathologic or pathognomonic of a pneumonia. They could be just mild basal atelectasis as a part of old age. There may be peripheral vasoconstriction, so peripheral pulses, very peripheral pulses may actually be absent in these patients, but the central pulses should always be found, and you should always be able to measure blood pressure in these patients. Let us now briefly talk about some of the common medical problems that are seen in these patients. Let's talk about cardiovascular disease. Cardiovascular diseases can have a lot of emergency problems. A lot of times patients present with cardiovascular complaints to the emergency department, and a lot of morbidity and mortality is actually associated with cardiovascular disease. And these are some of the common cardiovascular emergencies with which patients present in the emergency department. It could be angina, it could be a myocardial infarction, or it could be a spectrum of any other coronary artery disease. Patients can present with heart failure. There could be arrhythmias. They can present with aortic dissection or aneurysm. Hypertension and any of its complications, for example, left ventricular failure, for example, arrhythmias can present. Patients can present very commonly with syncopes because of cardiac disease, especially sinus node defects. Acute myocardial infarction also classically presents with features of chest pain, diaphoresis, sweating, nausea, vomiting. Many times it is important to remember that silent myocardial infarctions are actually quite common, and patients can present with very mild, very non-specific kind of chest pain as compared to young adults who present with very severe retrosternal chest pain with radiation. The common radiation to the left arm, to the jaw, to the angle of the mouth may be actually absent. Sometimes these patients can present only with dyspnea, and since dyspnea can have so many varied causes, one may actually misdiagnose acute myocardial infarction, especially in very elderly patients. Sometimes inferior wall myocardial infarctions can actually present only with abdominal signs. For example, there could be epigastric tenderness, there could be mild vomiting, there could be some rigidity. So one may actually think that the patient is actually having gastritis, when rather this patient would be having a severe myocardial infarction. So these are some of the atypical manifestations of acute myocardial infarctions that can present in the elderly population. Patients can sometimes present with very vague symptoms, for example, weakness, fatigue. Another important thing to remember is sometimes they could be having syncope because of reduced cardiac output, and that could be the only manifestation of an underlying myocardial infarction. There could be confusion because of reduced blood supply to the brain, and these patients can present with mild confusion or alteration in sensorium. Sometimes they can present with a TIA or a cerebrovascular accident when actually the underlying manifestation could be an embolization from an acute myocardial infarction. So these are some of the complications that can occur in patients with myocardial infarction, and that can be the actual presentations of myocardial infarction in these patients. Of course, if patients are presenting with very classical features like severe chest pain, breathlessness, excessive amount of vomiting, excessive sweating or diaphoresis, then the possibility of acute myocardial infarction becomes much more simpler as compared to somebody who presents with more atypical features or such atypical kind of presentations.
Ma'am, then if suppose an elderly patient is presenting like silent myocardial infarction,
Yes.
or maybe inferior wall MI presents as a abdominal symptoms, then how the what is the focus area need to be give more priority to diagnosis these symptoms?
Okay, the thing about silent myocardial infarction, of course, if a patient has no symptoms at all, then it is then it's in only ECG diagnosis. I mean, you will have to have an ECG for the diagnosis. However, if a patient, the reason why I said about the inferior wall MI is that suppose a patient is having mild epigastric discomfort and the patient has actually taken an antacid, has not had much recovery, what can be done is that you must always at least get a baseline ECG done in these patients. It's a simple test, it's a non-expensive test, and it's a test which will give you your diagnosis in most cases. So even at the earliest possibility that the patient could be having a myocardial infarction, it is always better to get an ECG done when patients present with vague symptoms, vague pain which you are not able to localize. Another important thing to remember as a connotation from this is that any sudden onset unexplained chest pain or dyspnea, even breathlessness, should always be evaluated for acute myocardial infarction. That is the second important message from this. So any unexplained chest pain or any unexplained breathlessness that occurs in patients these patients should always undergo at least an ECG to find out whether or not they are having a myocardial infarction.
Since the older age group has got more risk for this having the myocardial infarctions as compared to the young adults.
Yes, the risk of myocardial infarctions, risk for sudden cardiac death, risk for arrhythmias increases tremendously after the age of 75 or 80. So one has to be very cautious, and in fact cardiovascular disease is the leading cause of death in these patients. So any patient who presents with symptoms which are not very classical, one must always try at least get an ECG done. It is, as a rule, it is better that whenever an elderly patient presents with the medical emergency, one must at least get a simple ECG done. It could be the underlying manifestation, underlying disorder for a whole variety of manifestations. So it is very important to at least get one ECG done in any elderly who presents to the emergency department. The next disorder that we'd like to take is congestive cardiac failure, and there could be a whole lot of causes which can give rise to congestive cardiac failure. Because of decreased cardiac output, they can be just presenting with nocturnal confusion. There may be significant amount of edema and fluid-filled blisters which may develop in these patients, and that could be the only sign of congestive cardiac failure. It is important to remember that patients who are bedridden may not actually develop pedal edema, but if you examine their sacral areas or pre-sacral areas, they tend to develop sacral edema rather than pedal edema. Another, like we discussed, that dyspnea is a very prominent symptom in these patients, and shortness of breath can occur for a huge or a variety of reasons. So any patient who has dyspnea should be evaluated for underlying cardiac cause as well as for underlying respiratory problems. And some of them are mentioned here, but I'm not sure you're able to see it. I can just go through it. Congestive cardiac failure, chronic bronchitis, pulmonary embolism, pneumonia, pulmonary edema, myocardial infarction, asthma, emphysema. So if you see, this is a whole list of conditions that can actually present with one complaint, that is dyspnea. So it varies from an infective process such as a pneumonia to a cardiovascular disease such as congestive cardiac failure, myocardial infarction, to asthma, emphysema, chronic bronchitis, and even pulmonary embolism. So any patient who presents with dyspnea, and dyspnea is a very prominent complaint that can occur in these patients, one must rule out all these complaints. Again, if you want to rule out congestive cardiac failure or myocardial infarction or pulmonary edema, you will need an ECG. So that my point to stress here is that an electrocardiogram is a very important diagnostic modality in elderly patients who present to the medical emergency. The next common set of symptoms with which patients present on the common group of disorders are respiratory disorders. And the common respiratory disorders which are seen are pneumonias, chronic obstructive airway disease, pulmonary embolism, pulmonary edema, and sometimes even lung cancers can present dramatically in the medical emergency with emergent complications. Pulmonary edema or acute left ventricular failure, the causes include congestive cardiac failure, myocardial infarction, and other diseases of the heart valves. Most of these patients will present with orthopnea, coughing of pink frothy sputum. On examination of the chest, there will be multiple wheezes on examination. Pneumonia is a very common complaint in elderly patients. Many hospitalizations are seen in elderly population because of a pneumonia, and it can have very atypical presentation. It is common in the elderly due to aspiration. They have decreased immune function. They may aspirate, they may not be able to cough out, so they could be having pneumonia, which is common in these patients. Absence of cough and fever are very prominent. Patients generally or may present with only altered mental status. You may not have very much findings on physical examination other than maybe mild rales which are there on examination. They could be just basal, which could be assumed as insignificant. They could be having abdominal rather than chest pain, though classic pleuritic pain of pneumonia may be absent. So these altered or atypical presentations may occur, which may mislead the patient, mislead the physician from making a diagnosis of a pneumonia. But a pneumonia is a common condition, is a condition which is easily treatable. So one must always try to look for and rule out, and all it requires is a simple chest X-ray. A chest X-ray will pick up a large patch of a pneumonia even if the patient may not be having very obvious physical signs. So it is better that any patient who has atypical chest pain, any patient who has mild fever, any patient who has dyspnea, you should always get a chest X-ray to rule out an underlying pneumonia or a lower respiratory tract infection. Another important problem is chronic obstructive airway disease. Though chronic obstructive airway disease is a chronic problem, patient will give you a history that he or she has been having cough and breathlessness and expectoration of sputum for many years. It may be present, that it may present very dramatically in the medical emergency with acute exacerbation, that patients will have sudden onset increasing dyspnea. The most common cause of this is of course a chest infection, which increases the chest pain and increases the dyspnea. Another important possibility that one must always consider is a spontaneous pneumothorax in these patients. Many times COPD patients suddenly decompensate, present with severe breathlessness, and that could just be occurring because of an underlying pneumothorax. Another thing which can occur is multiple supraventricular arrhythmias, especially atrial fibrillation, especially multifocal atrial tachycardia. This can again, if the rate is very high, present with congestive cardiac failure and palpitations. So these are some of the important complications that may occur in patients with chronic obstructive airway disease who are otherwise stable, they destabilize, they decompensate, and they may present to the emergency department with multiple complications or present as an emergency situation. Pulmonary embolism, of course, if there is a blockage of the main pulmonary vessels, it may result. Most common cause is deep vein thrombosis from the lower extremities. So patients who are non-ambulatory, for example, patients who have been lying down in bed because of chronic some other condition, they will be having severe osteoarthritis of the knee and hip. They may have had a fracture of the neck of femur, and they may be immobile for a very long period of time. And these patients may then later present with sudden severe dyspnea and chest pain, and that could be just because of a patient who is having a pulmonary embolism. So it is a differential diagnosis that needs to be entertained in any patient who presents with sudden respiratory distress or sudden dyspnea in an otherwise patient who has a probable risk factor for development of an embolus, especially a deep vein thrombosis of the lower limb. Another important set of diseases with which patients present to the emergency department are neuropsychiatric diseases. We will talk about the neurological disorders. The common neurological emergencies that are encountered are cerebrovascular disease or strokes, seizures. Patients may present with dizziness or vertigo. They could be having delirium, and there could be multiple infections which can be present with any of these complications. It is very important to remember initially how to differentiate between dementia and delirium. Dementia is also a problem which is seen as age advances. More the advancing age, the more the chances of patient developing dementia, which is a degenerative process, which is an irreversible process, whereas delirium is a acute onset, sudden onset, loss of consciousness or alteration in sensoria, which is reversible if treated initially and picked up early. There are many distinguishing features between the two. Dementia is more chronic, more slowly progressive, whereas delirium is more rapid. Dementia, like I said, is irreversible, whereas delirium can be reversed if treated early. For example, if a patient has hypoglycemia and presents with delirium, if you treat hypoglycemia, delirium will get reverted. In dementia, there are global cognitive defects and impaired memory. Impaired memory could be there also in patients with delirium, but it is usually short-term memory which is lost, and many of these are focal cognitive defects rather than global defects. Whenever an elderly presents with altered mental status or alteration in sensorium, it is very important to remember whether this has been acute in onset or chronic in onset. Something which has an alteration in mental sensorium or a diminishing consciousness over a period of weeks or years, and which is of acute onset, they have very varied etiology and they need to be approached very differently. Another important thing, like I said, have stressed this earlier also, never assume that acute dementia or altered mental status is due to senility. If a patient suddenly deteriorates as far as neurological status is concerned, it is highly unlikely to be due to a dementia. There is always an underlying cause which needs to be found out, needs to be elicited, needs to be examined and treated. Many times, most of the times, if you can pick up the cause of delirium early, you can treat it before irreversible brain damage has occurred. So it is always important that in any adult who presents with altered mental status, one must always ask the relatives or other caregivers as to what the baseline mental status was prior to the presentation with this. Pre-morbid baseline status is extremely important to remember. If somebody has been showing signs of chronic progressive dementia over a period of years, that is very different from somebody who has been very conscious and alert till 3 days back and shows signs of deterioration in sensorium. So these are very two different conditions, and they can be found out only if we know what the baseline mental status of the patient was and how dramatically this loss of sensorium has occurred over a period of time. So in this situation, it is extremely important to ask good history from the caregiver or the attendant or whoever is staying with the patient daily, so that he or she may give us a good idea about the baseline state of the elderly adult. There can be numerous causes of alteration in mental sensorium. These can vary from electrolyte imbalances to cerebrovascular disease to infections to multiple causes. For example, head injuries with a subdural hematoma can present with altered mental sensorium. Multiple drug and toxins, for example, alcohol intoxication, drug withdrawal. Tumors can suddenly present with decompensation, raised ICT and alteration in sensorium. Central nervous system infections, pyogenic meningitis, tubercular meningitis, brain abscesses, encephalitis again can present with altered mental status. Electrolyte imbalance is very important. Hypoglycemia, hyponatremia, hypocalcemia all can present with alteration in mental sensorium. Cardiac failure just because of a reduced cardiac output can result in mental status. Hypoxia, respiratory depression because of maybe a large pneumonia can give rise to deoxygenation and hypoxia, and that can present with altered mental status. Hypoglycemia, especially in diabetics who are on oral medications, who have missed food, can give rise to severe alteration in mental status. So if you see this whole varied wide list of disorders that can present with one common presentation, that is altered mental status. So hence our examination, our history taking should be very thorough, and our investigation should be directed towards whatever complications or whatever condition we think the patient must be having. Cerebrovascular accidents could be present, could be embolic in origin, could be thrombotic in origin, or could be hemorrhagic. And these patients may have a prior sign of a transient ischemic attack, which could be very subtle. There could be just some mild dizziness, some behavioral change, which may have been missed by the attendant or by the patient himself, and then patient presents with the stroke. Headache, especially if localized, is quite severe, and sometimes there may be head injury which may actually delay the effect of the stroke presentation. And however, if a patient presents with evidence of hemiparesis or monoparesis or facial nerve palsy or other kind of focal neurological deficits, one must always think of the possibility of a stroke, and one must always look for underlying risk factors, for example diabetes, hypertension, which are uncontrolled. Patients may be having other common dyslipidemias which could act as major risk factors. So in a patient who has potential risk factors for development of a stroke, one must always try to find out whether there were any present, especially ask for the presence of TIAs or other subtle neurological deficits which were reversible prior to the presence of the stroke. Another important neurological emergency which occurs in elderly patients is seizures, and again there can be a number of causes of seizures. Remember, it is very unlikely that an idiopathic seizure disorder will present for the first time in an elderly adult. So although younger adolescents, younger children can present with an idiopathic seizure disorder, one must never label an elderly patient as having a seizure disorder unless this patient is known to have seizures for last 20-30 years. All seizures in the elderly are invariably having an underlying condition, and one must find out the cause for it. CVA, arrhythmias, infections, alcohol, drug toxicity, tumors, very importantly, head injury, hypoglycemia, hyponatremia, hypocalcemia, all of them can manifest as seizures, and it is extremely important to find out the cause for seizures in such patients. Syncope. Syncope is a very common problem with which patients present in the emergency department, though by the time the patient has come to the emergency, usually they have recovered from the syncope, because syncope is very transient loss of consciousness. But one should always be alert to the underlying cause for the syncope and look for those causes, especially rule out sinus node defect, rule out other causes. For example, there could be a TIA with which these patients present, and MI may present with the syncope. Another important group of things to remember is many times patient may be on beta blockers for hypertension. So they can cause syncope, and even volume depletion because of severe GI blood losses or even severe dehydration because of diarrhea can give rise to syncope. So before we label a syncope as benign in an elderly, one must always rule out the other causes which can give rise to syncope in these patients. Depression, although is a common problem and may account for chronic problems, many times it can present severely in an acute state in a medical emergency, and one must treat it immediately, as many times these patients tend to be suicidal and can have suicidal attempts. GI disturbances and GI disorders commonly present in the medical emergency with many problems. These patients can have upper GI bleeding. Even a single tablet of an aspirin or any other NSAID that the patient has taken can give rise to severe gastrointestinal bleed. They can even present with lower GI bleed. Another important point to always remember in any elderly who presents with an upper GI or lower GI bleed is the possibility of an underlying malignancy. One must always remember an upper GI malignancy or a lower GI malignancy can present as a GI hemorrhage. Bowel obstruction, small bowel obstruction can occur in these patients. severe mesenteric infarction and can present as an acute abdomen or an acute abdominal condition. Another important group of conditions which occurs or which presents with these patients are endocrinological emergencies. Some of these may be known, some of these may not be actually known. In a known diabetic, if a patient presents with alteration in sensorium or altered mental status, one must always think of hypoglycemia, especially patients who are elderly taking oral anti-diabetic medications, patients who miss meals and still take their oral anti-diabetic medications. It is important to remember that hypoglycemia is a common event. It is a reversible condition, very easily treatable. So, and if delayed, if treatment is delayed, it can actually give rise to irreversible brain damage. So, one must always check blood sugars in patients, elderly patients who present with alteration in mental sensorium. Non-ketotic hyperosmolar coma and ketoacidosis are relatively rarer as compared to hypoglycemia, but there are many factors which can actually predispose elderly patients, especially elderly with diabetics, to non-ketotic traumas. But remember that most of the time you will get a history that the patient is a known diabetic, and then one must consider these emergency situations in such patients. Contrary to this, mixed edema coma can present very significantly, very dramatically with hypothermia, hypoglycemia, altered mental status without the patient ever having known that he or she is having hypothyroidism. So in any patient who has severe hypothermia, hypoglycemia and hyponatremia, one must suspect the possibility of mixed edema coma, since this injection of levothyroxine or even tablet of thyroxine crushed through the Ryle's tube will give rise to very significant and dramatic improvement. If untreated, mixed edema coma can have very significant morbidity and mortality with it. Although I will not touch it in great detail, since the next topic is going to talk about accidents and falls. Another common group of emergency situations are trauma, and common emergencies which are seen are orthopedic injuries, burns, and head and spinal injuries. And why these patients, or why fractures are common in the elderly are because the common fractures seen are hip or pelvic fractures, the proximal humerus fractures, fractures of the distal radius and proximal tibia, fractures of the thoracic and lumbar body. So these patients can actually present with collapse of the vertebra, pelvis or hip fractures, and other kinds of multiple fractures. Head injury is quite common in these patients, more likely even with minor trauma. So patients, even if they fall off the bed or fall off a chair, which may not be a very significant trauma as for a young adult, it's a very trivial trauma, can give rise to severe head injury and loss of consciousness. Patients may present with, may have actually forgotten the injury, and the presentation may be much later. It can present as a CVA, it can present with mild neuropsychological manifestations because of a subdural hematoma. So one must always try to probe for the presence of a head injury, even though if it is very trivial or if it is very mild. Whether the patient has noticed it, the attendant may have noticed it, so it is always important to ask for a head injury. Cervical cord injuries, cervical neck injuries because of osteoporosis, narrow spinal canal, increase the risk of injury. What can happen is that these patients can develop severe quadriparesis if untreated and unrecognized, and it can give rise to very severe problems later on. There can be hypovolemia and shock in these patients. And the last words about environmental emergencies. These patients tolerate extremes of temperature very poorly, and there are multiple other factors. One must always have a high index of suspicion for this: hypothermia, hyperthermia. I will not talk about drug effects and toxicities because that is going to be the next topic, and that is toxicological emergencies. And geriatric abuse and neglect should always be kept in mind whenever we are dealing with elderly patients presenting to the geriatric emergency department.
Yeah. Thank you very much, Dr. Anuradha. Actually, Dr. Anuradha discussed in a very brief, the very large topic in a very simple way, so that all of you can understand. The main important here is the things Madam want to make you understand is, there is a saying that your eyes cannot see what your mind doesn't know. Like, you are working in a primary or secondary healthcare setup where all the investigations may not be possible, like ECG is easily available, chest X-ray is easily available, but in case of neurophysiology, neuropsychological and delirium and all these things others. So you have to be very much concerned about their history, their examination. Until unless the things are in your mind, you really cannot find it out. And definitely, like investigations like GI bleeding and all these things, the endoscopy, all this facility may not be available. So you have to be very much thorough and you have to be very much concerned about this, their physical examination as well as history taking, and try to pinpoint the exact problem of the elderly patients. Thank you very much to all of you, and we will again meet after 15 minutes for the next sessions. Thank you very much.